Thank you everyone for joining us today. We have Dr. Mark Froimson, who's a Weatherhead alum of 97, and he's the principal at Riverside Health Advisors and chief medical officer at AngelMD, sorry. And then we also have Dr. Trey Barksdale, who is a med student here at Case, who's going to moderate the discussion today. Just a couple of housekeeping items. If you have any questions at any point that you would like to ask, please either raise your hand or post them in the chat, and Trey can call on you. So I'm going to hand over to Trey to moderate, and look forward to this discussion.
Perfect. Well, thank you for the introduction. This is a pleasure today, first of all, to have a conversation that is a very open platform. So if there's any questions or anything that comes to mind, please feel free to share it. And then also to talk to Dr. Froimson, who I've had the pleasure of getting to know the last few weeks from a standpoint of both a medical profession and also within business and entrepreneurship and then innovation. So hopefully today will be that platform so people can learn, throw out ideas, and hopefully we can leave here, with like-minded ideas, but also have grown in many ways. And so I'd just like to start this, Dr. Froimson, by just kind of opening up who you are. You did a great introduction already, but who you are and kind of what you do.
Yeah, thanks, Trey. And, first, let me just thank all of you for the invitation. It's a pleasure to be here. I always wonder when I get these invitations, kind of what's the right format and, whether anybody's going to be interested in my story. But I know my dad's on, and I think my mom might be on. So that's always at least two people who are interested. So anyway, I'm really excited about talking to you and sharing some of my journey. Michael asked me to be a guest here, and usually I'll give a lecture with these types of things. So I really appreciate this format, which allows us to kind of have a conversation and exchange ideas about what it means to be a lifelong learner, which I think is really the essence of why we do these things. I mean, anybody who is tuned in is doing so because they're either in the process of learning and achieving a degree or because they anticipate being on a journey of lifelong learning. And so, I think what you want me to do, and I'm happy to do it, is share a little bit about my journey just to kind of set the tone. And then hopefully we'll have a conversation about a number of different ideas about how to view your journey through life, how to contribute to society, how to think about big ideas. At least that's what I think I do on a daily basis, and I continue to try to do that. So I started out, my dad's an orthopedic surgeon, so I always had an idea of going into medicine. But I actually started my education as an engineer, and I went to Princeton as an engineering student, and looking back on it, that was probably the right place to be at the beginning of the computer revolution. But as I progressed, I actually decided to abandon engineering at that time and study philosophy. And I majored in philosophy at Princeton, and really, come and think about that. And my parents had a lot of dismay about paying for that kind of education that had no practical value. But as I look back, I mean, everything I do today is about critical thinking, about the exploration of meaning, about the search for truth. And I think we can all say in society today, this search for truth, especially in this era of uncertainty about what you're being presented online, is probably one of the most critical topics. Like, what do we know and how do we know it? So anyway, I will come back to that, but I studied philosophy. I did my pre-med, and I thought about, life, and I thought about, the human experience, and what better way to really explore the human experience but to be a doctor, right? Because what we're thinking about in philosophy is, what's the meaning of life? What is the purpose of being here? What do we know? And to go to medical school and to have the opportunity to study the human condition, I think it really aligned with that. And I went on to become an orthopedic surgeon, much like my father, had the extraordinary pleasure of practicing with him, of having a like a little family business where we would do 2 total knees, and he would do always the right knee and I would do the left knee because we're both right-handed. And for those of you who don't know, if you're right-handed, it's easier to do the right knee. So I'd let him do the right one and I'd do the left one. And then we would go to the patient and see which one they like better. So medicine, great career. But I think one of the reasons that you're interested in kind of what I am doing is because I have pivoted throughout my career in medicine as I've thought about sort of a return to systems engineering. And back in 1994, I remember very specifically deciding to get a business degree. So I launched my career in orthopedics. I was having a great time. And then I was reading JAMA, the Journal of the AMA, and I was reading about healthcare reform. And at the time, Bill Clinton was president, and he had assigned Hillary Clinton the task force of changing healthcare, and that healthcare was broken. And it struck me at the time that there had to be a role for physicians to look at systems like the healthcare system, and think about, what was our role in improving the system? Because certainly it wasn't going to be improved through through politicians, through businesses, but maybe physicians had a role. So I went and got my MBA, had a great time doing it, and then practiced orthopedics. And I realized as I went to business school that there was a real difference in the way we were taught in medical school versus business school, because I kept asking for more evidence to make a decision. And in business school, they told us, just make a decision. You don't need another diagnostic test, and you don't need another, you don't need more information. So it was kind of an interesting dichotomy. But through that process, I had the opportunity to be able to step in healthcare, to be able to step in when I was at the Cleveland Clinic and was asked to chair a committee on blood utilization. And it turned out the Cleveland Clinic had the distinction of using more blood products, of transfusing more blood than any place in the world. And Toby Cosgrove approached me and said, you've got an MBA. Can you solve this problem for me or for us? And I said, yes. And it was part of that philosophy that I've come to adopt, and that has kind of taken me through what I've done, which is the philosophy of always saying yes. And when someone comes to you as a clinician, a patient comes to you with a problem, it's your job to say yes, because what an honor it is that someone comes to you and asks for help. So you need to say yes. But also, as in any field, in any endeavor, when people come to you and ask you for help, you should always say yes. I've heard and read so many articles about the importance of saying no, of prioritizing and learning to say no. And I fundamentally don't agree with that. And that's where my path has gone, is this opportunity to say yes is so important, because that's what opens doors to new opportunities. So I'd say yes to Toby. And ultimately, I got increasing responsibility through the Cleveland Clinic, and really started to think more thoroughly about this idea that physicians need to be the agents of change and improvement in healthcare. And ultimately, I got into the administrative side, was asked to run one of the Cleveland Clinic hospitals as a hospital CEO, and then, went on to Trinity Health as their chief clinical officer, and just was able to take on increasing responsibilities to re-engineer systems. And so ultimately, I came back to this notion of being an engineer in a certain way, to really say, look, as a physician, our task is to help an individual patient. And I think it's important as physicians that we look at the healthcare system as an ailing patient with a complex series of systems, and try to figure out how we can give back to it. And so then following that, just to kind of finish the journey and where I am today with Riverside Health Advisors, one of the things that I learned along the way on these executive teams was that innovation was often stifled at the front door of healthcare systems. And I found entrepreneurs with great ideas and great solutions not understanding the pathway to success in a healthcare system, like not having a great solution, but a solution in search of a problem. And so I ended up leaving an executive role at Trinity and starting both my role at Riverside Health Advisors and at AngelMD, where I now mentor entrepreneurs, and I help early stage companies, some late stage companies, some public companies apply their solutions in a meaningful way to improve patient care. So I'll stop there. I don't want to, meander too much, but I thought that would give you kind of a little bit of a sense of kind of where I am today.
No, thank you for opening up. I think the most important thing is you really gave us a good background of everything that you've done. And I know we had talked originally kind of about what you've done, and where your interests and passions have come. But for all of us, I think the thing we really want to know kind of is, with this career in orthopedics, do you feel like your interest in business was stimulated kind of early on, or that it was, like you said, later on when kind of you saw this problem within the field? And for us, do we have to get to the point where there's a problem in the field to then hopefully kind of make these changes, or if this is something we should kind of be thinking about now and how we can kind of address these things?
Yeah, so I think it's a natural part of what we do as physicians to understand that we are in the process of making decisions that have significant implications for a whole host of domains, the clinical domain clearly, but the resource utilization domain as well. So we have, there's an old adage that used to be true, which is the physician's pen is the most expensive part of healthcare, because what the physician writes ends up in orders that yield significant tests or procedures, et cetera. Now it's the keyboard or maybe the touch screen. But the essence of it is still true, that, a physician making a decision, a clinician making a decision, is the driver of resource utilization. So we have always thought of ourselves in this purely clinical domain that, well, I need to do whatever it takes to benefit the patient, spare no expense, right? Order every test, do it. Even the way we're taught with this concept of a differential diagnosis, the differential diagnosis means think of everything that's possible and rule them out, right? Rule them out one by one. And that's a very expensive process. It defies heuristics in a way of thinking. It's really meant to be fairly comprehensive. And it clearly results in significant waste. And we see tests that are ordered that are unnecessary, procedures that are done that are probably not marginally beneficial. So in orthopedics, that was an easy field because there are certain elements in healthcare that ought to be fairly predictable, where a patient comes to you and you ought to be able to tell them that there is a pathway that we're going to take and an outcome that we expect, and you ought to be able to engineer it. So in my field, which was hip and knee replacement, that was one of the really tips of the spear, so to speak, in the economic analysis of clinical decision-making. And it was often one of the leading paradigms for value-based care, which is to say, look, it's not a mystery what's going to happen to you if you're going to have a knee replacement. We know, we've engineered this in such a way that we should know every step. So I was fortunate to be in orthopedics and fortunate to be able to use some business concepts to go down that path at the Cleveland Clinic, and was given a lot of leeway to initiate things like service line cost management, where we looked at, variation in care and why did one surgeon do one thing and another surgeon do another. We discovered it through the course of that following a knee replacement, your chance of being discharged to a nursing facility versus going home there could be a 5-fold difference simply based on who you were given an appointment with. It had nothing to do with your clinical determinants. It had to do with the preferences of the physician. So I was fortunate to be able to be in that spot, to be able to use some of the teachings from business school, and to launch things like value-based care initiatives, bundle payment for care improvement initiatives, and And ultimately, I had the opportunity when I was the president of Euclid Hospital and a practicing surgeon. So one day I would be in the operating doing surgery, and the next day I'd go behind the desk as the CEO of the hospital to really see what would happen when I talked to myself, one as a surgeon and one as the administrator, and make changes and increase the efficiency of the system. And that's what I think we're all crying out for when we see the escalating cost of healthcare, the inefficiency, the waste, the inequitable access, the challenges in healthcare. And I think it's our duty as physicians to not sit by and accept the criticism that we have and that's leveled on us without trying to improve upon it.
No, that's very good. And I think one thing you brought up at the end was something that I've been very interested in is kind of what you bring to the table as a physician that also has an understanding of both innovation, entrepreneurship, and how you kind of brought those together. And you talked about that a little bit, but being able to come, one day you're in the operating room and the next day you walk in and have to look at the finances and have to assess kind of how to impact the trajectory of a hospital system, and how things are run. Like, how did you combine those two and be so successful with those?
Well, I don't know how successful I was, or, I think we're all still trying, right? But I think that the key here in my mind is questioning assumptions. And this is something that I come back to a lot in my thinking, which is that none of us are going to see the opportunities in front of us unless we're able to question the assumptions that we're holding, and to question those assumptions so that we can test whether what we're assuming is true. I mean, most of us have to go through life. You can't analyze everything in real time, so you create these shortcuts, which are assumptions. And, they're in healthcare, they're all over the place. So the way we do things is often just, why do we do it that way? Well, it's the way we've always done it. Why do we do that? Because we assume that when a patient comes in, for a pre-op preparation on the day of surgery, that it needs to take 2 hours. Why does it have to take 2 hours? Well, what are we actually doing? Right. And so as we start to break down the processes, we can see that maybe there are things that we're doing sequentially that we can do concurrently. Maybe there are steps that we're doing that are redundant that we can omit. Right. So there's a certain level of redundancy and safety built into most of our processes. And then we assume that we have to continue those because that redundancy is essential to safety. And we have to then ask the questions over and over again. At what point is this process overly redundant and therefore wasteful? We had a situation when I got to Euclid Hospital where patients would come in, they'd be checked in on the first floor, then they'd sit there for a while with a nurse, then they'd go up to the second floor, they'd get checked in again. And if you were coming in fresh like I was, you'd look at it, you'd say, this is like, does this make sense? But if you were doing it and it's the way you had always done it, you didn't know, number one, that it didn't make sense, and number two, you didn't know that you had the permission to question it. Right? Often we're doing things and we're in a pattern of activity, and we don't know that we have the permission. So we have to give our teams the permission to question the assumptions that underlie their thinking, so that we can work as a team to try to improve the processes that we're following.
No. Thank you for that. And I know when we had started this conversation, we went through everything you've done, and now you're currently working with Riverside Health Investors. Can you give us a little bit of insight, what you're doing with them, what brings you passion with your work with Riverside Health Investors, and kind of the trajectory of that now?
Yeah, so I have a great situation that is, what I basically do now is I advise entrepreneurs. And so I find people who are pursuing a problem in healthcare that I think is worth pursuing, who may have a great tech stack, may have a great set of digital health tools, may have a I've got a whole bunch of companies, so there's lots of different examples of what they're doing in terms of they have the essence, they have developed something, a product or a service, but what they're lacking is an understanding of how to connect that solution to a problem that real people are having. And so what I often do now is translate and draw either a straight or dotted line from a problem that a decision maker is having to this solution, and trying to help them tell their story in a way and strategize about how to approach the marketplace, how to approach the people who are facing that problem that would benefit from the solution, and make the case compelling. And so we've got, over a dozen companies, getting close to 24 companies where, our role is first to identify companies of promise, where there's clearly a differentiated solution, clearly a talented team, clearly a problem we're solving. And there's kind of a rubric there. There's a certain set of criteria that we look at. And then in a circumstance where we can add value, that we can provide guidance to the executive team, generally at the highest level, to help them adjust their strategy, to provide some networking and introductions, to maybe adapt the product or service so that it's more usable. And that's what we do. So I have companies that range from a company that does virtual reality training for surgical procedures, which is, right now mostly in the orthopedic domain. I got connected with them a couple of years ago and provided some early advice to the CEO. And it's been an amazing time for that. If you can imagine, with COVID-19 and the challenges that you must be facing as a med student and that residents are facing, this idea of virtual reality training has suddenly really taken off. It had intrinsic value before, and we've been able to demonstrate that VR training improves retention, improves team-based learning, and improves performance of residents. So it's a great modality, but of course it's really gone into this into hyperdrive as companies, as educators really can't bring people together and need to be able to educate remotely. So that's what we do. I help start companies if that's helpful, but often there are companies that are ongoing, and we provide strategic advice to them. And it's fun. And it's like, for me, I'm not teaching residents. I mean, one of the great joys of surgery was always teaching residents and fellows. But now this is sort of a second act where, these are young entrepreneurs generally. And it's really very similar to teaching residents and fellows. So it's a lot of fun.
Yeah, it seems like, and then we've had a lot of good conversation about about kind of what you're doing and the innovation in those fields. We do have a question that's come in from Rachel Weitzman. So can you talk a little bit more about how increasing efficiency of process at CCF can help improve health equity? I think it's a very good question. Thank you.
Yeah, so I think it's a really, there's a twofold question, which is, should we all be focusing more on health equity? Which is absolutely the case. And I think, when you talk about what are things that I'm really interested in, one of them is health equity. And, one of the challenges with, our healthcare in general is this sense that there's a scarcity of resources, right? So, I mean, one of the underlying principles that we have to, maybe uncover, an assumption, if you will, is that health equity is at least in part driven by the sense that there's a scarcity of resources. Because if there were abundance of resources, if we all believed that there was more than enough for everybody, then one would assume that it would be a lot easier to distribute it and that health equity would be less of a challenge to overcome. So, one has to think that part of what's driving health equity, certainly not all of it, or inequity, not all of the problem is a lack of sufficient resources to deliver healthcare to everybody who needs it. And so you would imagine that if you're wasting resources, if you have a clinic where your processes are inefficient, where the bottlenecks are occurring, and the throughput is limited, then you're not deploying your resources effectively. And so therefore you can't take care of as many patients. I used to say one of the principles we should have is that because we are really good at what we do at the Cleveland Clinic, is that we should endeavor to deliver our services to as many patients as possible. That's our duty. If you believe you're really good at something, then it's your duty to be able to offer it to as many people as possible. So, so I think that, efficiency, and these are business concepts, right? I mean, you have to look at everything you do in healthcare through the lens of where are the bottlenecks, there's queuing theory in business school, there are bottlenecks, there's throughput, and you need to really understand that in order to take an operating room that maybe does 4 cases a day and ask yourself, like, what is the actual time that surgery is occurring? Well, if the operating room is available for 9 hours a day and each procedure actually takes an hour, so you're using it for 4 hours of surgery and then 5 hours of other stuff, right? The patient coming in, the patient being prepped, the patient sitting up, talking, asking the patient the same questions that we just asked them in the pre-op area, right? And I'm not saying that all of that isn't necessary, but we took a look and we had a project where I got a little bit of heat for this. I said, look, this should be entirely predictable. From the moment a patient enters the room, we should know exactly how long it takes us on the average case. Now, there'll be outliers, but for a typical case, to get from patient entering the room to an incision. Shouldn't be a mystery, shouldn't be a lot of variability. You should know the patient comes in and do it by the clock. And people would say, oh, patients are all different. They're not that different. Like if we have that underlying assumption in healthcare that patients are so different and so varied that we can't standardize and commoditize some of our practices, I think we're fooling ourselves. And so, and you have to measure things. If you're not measuring them, you can't improve them. And there's a real challenge to getting people to adopt that philosophy. I think we're seeing it more and more in healthcare, but that has really been a journey from when I started to until now.
Thank you for that. Ms. Das, I think you have a question as well, if you want to ask it.
Sure. Thank you, Dr. Froimson. That's an awe-inspiring journey, quite frankly. You mentioned that when you were CEO of Euclid Hospital, that you mentioned that we have to give our teams the permission to question the policies and processes, right? But that is from the perspective of clinicians. Most of the examples that you have cited are from the perspective of a clinician. For those students of healthcare management that come from a non-medical background, what are the opportunities for us to serve as change agents of the healthcare system? Can you comment on that?
Yeah, I think it's a great point. I really believed in a concept that we had that said everybody's a caregiver, right? I used to talk to our CFO and joke, and it really wasn't a joke, that when you send a bill to the patient actually has more encounters with our billing department than they do with our clinical teams, right? And so you have the ability to impact the patient experience as much or more than the clinicians do, right? So you have to think about every process, every aspect of the interaction, things that might seem mundane, like, what does the parking lot look like? How do patients, get from one place to another? Every element within the both inside and outside of the healthcare encounter, it impacts patient experience. And for us to only think that it's the clinicians who impact our patients doesn't make sense.
Sure, but is it that the leadership roles are usually from those people who walked in clinician shoes?
No, I don't think so. I mean, I think traditionally the leadership roles were actually the opposite, right? I mean, it was rare for a physician to be a health system administrator until recently, right? So I think what you see now is like kind of paradigm shifts that go both ways. When I started, there were no physicians essentially in leadership roles. We had professional hospital presidents who were business people who ran the business affairs. And then there's been this movement led in large part by the Cleveland Clinic and by models like that said clinicians need to get more involved. But that shouldn't be mistaken for the concept that physicians are solely the people who should be in leadership roles. What I like to say is that we all are educated using different languages, right? So when I go to medical school, I learn a language of clinical language, and it's a specific type, not just the words and the vocabulary, but a specific way of asking questions, a specific way of solving problems that, as I learned, was different than what my colleagues in business school were learning, right? There's just different approaches. And if I, as a clinician, don't learn the language of my finance team or my HR team and understand what's important to them and what is driving them, we're not going to function that well as a team. And the same thing with them. If they don't understand that there's not a big mystery behind clinical practice, one of the things that I think we have done a very big disservice regarding as clinicians is that we have tried to make clinical medicine seem like a mythology, like it's a mystical thing that you're no one, if you're not a clinician, you're not allowed to understand it. The truth is that it's not that complex. It's, and all the physicians or med students, might argue with me, but we're just learning a specific set of tools, a specific domain. But it shouldn't. We shouldn't be without question, right? So if we behave like that we have some kind of specialized knowledge that doesn't deserve to be questioned by people outside of our domain, then that's the assumption that needs to be questioned. So I hope that helps.
Thank you very much. Yes, it does. Thank you.
Hey, my name is Akil. I'm also a MSM healthcare student. So given your background in as a doctor and then also with entrepreneurship, what are some successful innovations that have been proposed to you at your roles at Riverside and AngelMD? I know there's been a large shift in the past decade or so to value-based care, right? Some things you had mentioned previously was also bundled payments, but anything more specific or anything else besides those?
Yeah, I mean, I don't want to promote any specific company that I'm working with, but there's a big challenge in healthcare right now, which can be termed the digital front door. And I work with a number of companies that are trying to address that. So if I can go on Amazon right now and get a whole plethora of options of what I want to buy and understand the attributes of that. And I can have a great shopping experience and use whatever limited knowledge I have about some very specialized things like a TV or, things that I don't know all the different ins and outs of the engineering, but I could pick a TV and have it sent to me. When you go on the digital front door of healthcare, even places like the Cleveland Clinic, who are reasonably far ahead, that experience is still somewhat stunted. I can't make an appointment. I had to get some blood work done not too long ago, routine blood work, and I went on to try to schedule an appointment because now you can't just walk up because of COVID. You have to schedule your time to get your blood drawn. You couldn't do that, right? So there wasn't a place to schedule it. And so then I had to call a number, and then they transferred me to another number, and they transferred me to another number. Now, can you imagine any other consumer experience, digital experience, where that would be satisfactory? It just doesn't happen now. We are all accustomed to being able to transact most things and get some reasonable degree of progress on it. So a number of companies, I work with a company now that you can go on the app. You can put all your information in. You can put your insurance card in. They can run your benefits. They will know exactly what your copay is. You don't have to go sit in a waiting room. You don't have to fill out any forms ahead of time. You don't have to actually answer any questions when you go in to see the doctor. They have all your information. So those are the types of innovations that healthcare needs, and that we're seeing, and that a company like that needs help, because health systems would say, look, we have Epic. That's all we need, right? We have an electronic. I got my chart. That's all we need. I don't know if you've been on my chart like I have. It's not a consumer experience. It's a provider-based charting system where the consumer experience is not even close to anything else that you will have in your shopping experience. And people say, well, healthcare is not shoppable. That's not true. We should make it shoppable to those. I mean, there are certain things, like if you have a fracture or a heart attack, maybe you don't have time to shop for it. But if you're having a knee replacement, what I deliver, you should certainly understand what attributes are involved in the care that I'm delivering, and also what the costs will be to you, what that experience will look like. We should be able to package that and create a competitive environment that's much more conducive to consumerism and basically patient engagement. We should trust patients with more tools and better information. Again, I come back to this idea that we have put up this big shroud around healthcare, like it is not something that you can shop for. But I would argue that it is. Great, thanks.
Thank you. Yeah.
I think we have another question that's coming in from Michael.
Hey, Mark, how are you doing?
Good.
Long time no see.
Yeah, hey, how are you?
Good, good. I had a quick question. I know you have experiences as an investor, as a leader in a hospital system, as a surgeon, on boards of public companies, therapeutic companies, to diagnostics, devices, health IT. You're a man of many. You got your hands in a lot of pots. I'm curious, and I see the direction of the conversation going towards health IT, but given your experiences, I guess my question is, what really gets you the most excited about quick impact on the health system, given all of the projects that you have going on?
Yeah, you want to give a little pitch on your company? Because I mean, you've got something that's really innovative, and I think
Yeah, sure. I'm with Hyma Therapeutics. I'm the CEO at Hyma. It's a technology licensed out of Case Western that's developing synthetic platelet surrogate products to be administered intravenously to stop bleeding, and to support platelets that are in circulation. And it's something that can be dried down to a powder, thrown onto an ambulance, given to military personnel taken out into the field to help save lives and help control bleeding. So I've been bugging Mark for for a long time to kind of support us in the fundraising side of things, but I know he's busy with a lot of other aspects of business development.
Yeah, so those conversations keep going. So I just wanted to give you a chance to give your, to make sure people knew that you're working on something. Look, I mean, therapeutics.
I'll use this plug. I'm still looking and continually evaluating students as interns within the company.
Perfect.
From a business background as well as from a scientific background. Yeah.
So, but I want to answer your question kind of in a broader way, but and then talk to you about a company that I'm really that I is totally off the wall and different, but is really exciting to me. But we're always looking for things that are like paradigm shifting, that are going to solve real problems, and that I always say, and I talked to Trey about this, like. You have to ask three questions in healthcare entrepreneurship and innovation. They have to be, what problem are you trying to solve? Like, who's going to be happy you solve that problem? Like, who's going to come knock on my door as CEO and say, thank you for solving that problem. That was a problem that kept us up at night. Or I can go brag to my board or somebody and say, look, we solved this problem. And then third, which is often the most challenging, is who's going to pay to make that person happy? Right? Because someone's got to pay for it, and we can't pretend that, everyone just wants solutions. And often, like, you need to tell me whose budget is this going to come out of?
Yeah.
So I'll tell you about something that's not health IT. This is in the substance use disorder area. The opioid epidemic. I had a friend who was recovering from substance use disorder who wanted to start actually a digital health company. And we pivoted from that. And the problem that was being solved was that patients who OD come to the ER and we give them Narcan, right? We figured out how to do that. We make Narcan available everywhere. We can, someone who's having an OD, great, give them a Narcan. They wake up, you give them a tuna fish sandwich, and then you say, all right, you're good. See you later.
On your way.
And those patients come back routinely. They don't have anywhere to go. They don't, it's a sad state of affairs. And it's like this hamster wheel. It just keeps going.
Yeah.
And so we said, well, what would it look like if we embedded peer supporters into the hospital ER?
Yep.
And so we put this program called Thrive Peer Support. We built a company around it. And over the last couple of years, we have now hired people who are in recovery to be peer supporters, to staff ERs across not just Cleveland, but across the state. We provide outpatient care and connect people and help people who are seeking recovery by connecting them with somebody who's been there and providing them with, kind of a lifeline or a coach or a peer who's going to get them there. And we've now hired over 100 peer coaches. And these are people who, have records, have past experiences that often make them difficult to employ in other circumstances, but we've been able to employ them. So that's like, if you want to know what really gets me excited, like that's a great business that we started because we saw a real need and the health systems were very happy to solve it. And we were able to get a pathway through Medicaid reimbursement to make that happen.
That had to be tricky with Medicaid reimbursement. I can't even imagine. I know I have a cousin that actually helped get the Veteran Affairs Drug Court up and going. And it's a very similar model of providing, not just throwing people in jail, but providing them peer support in a similar way. Like, don't just throw these guys on the street, but give them the personal support system to make sure they don't become recurring patients. Yeah.
So the idea is like find a real problem that needs a solution and go after it. So for any of you entrepreneurs out there, to me, that is, that's the essence of this. Thanks.
Cool.
Also, I want to, this Mahmoud, to really, first of all, thank you. Great discussion, you and Trey, and thank also Michael for offering to support our student. I would really love if, because the students are on this call, if they need any, sometimes they have some ideas and whatever, if you can allow them to reach out to you, because that's one of the things which is important is we try to build these bridges. So I really appreciate that.
Yeah. So, and I want to come back to I say yes. So, that's what I said earlier is yes. And I'm going to say yes to you. And I have a philosophy, like I alluded to, which is it's not just yes, but it's always a yes, comma, if. And so when someone comes to me, then it's up to me to set the guidelines and the criteria that need to be met for me to be able to move forward. So, I'm happy to take anybody's ideas or mentor anybody. To me, that's what's really fun. I am in that stage of my career, having been the recipient of great mentors and great leaders who have given me an opportunity, that you reach a point in your career where it's important to give back, and it's important to make sure that you're enabling others to achieve what's possible, and that you're opening the doors to those possibilities. So to answer your question, I'm wide open to that. I'm not going to necessarily make it easy because that's not what somebody wants. What they want is to understand how to get to yes and what the conditions need to be in order to get to the next level. So yeah, I'm absolutely open to that. So thank you.
I just want to comment about what you said. I really absolutely agree with you. And once when we started, Joe would tell you, talking to our student who just came in and joined, I said, guys, we are doing this because we'd love to help and move. But you have to have the elements and the passion and the stuff so that it could happen. So don't depend on people coming to you. It's like what you said. You really have to go after it. So I agree with you fully.
Yeah, absolutely. Thank you.
Well, I think so. I know we're running close on time, and I want to be respectful of everybody's time. I know Zoom has been very overwhelming these days, kind of constantly sitting on Zoom. But I think we had one more question from Tarun, and I want to give him the opportunity because he asked it a while ago. If he still has that, if not, we can kind of move forward.
Yeah, I can ask it quick.
Yeah.
Thanks for being here, Dr. Froimson. Enjoyed the talk.
Sure.
I'm a medical student, and I think something I've been hearing about lately is, a lot of us sort of read the theory and the principles around like value-based healthcare and delivery and competition. We read Porter and Teesberg, and so like, oh yeah, that's going to work out great. And then when we talk to people that are running hospitals and departments, it's sort of that there's all these other pressures that make things a lot more complicated. And I wanted to ask the specific example of with technological innovations and sort of the pressure from the administrative perspective to sort of keep up with the arms race, and how, whether or not something is really providing value to the patient or to the customer is different than whether it's perceived to be providing value. And I think, you look at models in different countries and stuff, and all these different systems, they have to sort of vet things for cost effectiveness. But even in those models, you can sort of play around with the variables and define the problem in such a way that you are able to solve it. So I just wonder, from your perspective, how you're able to discern, is this a problem that really exists? I won't knock on any particular companies or any specific products, but I think there's a lot of people out there and a lot of entrepreneurs that are, have fantastic intentions and motivations, but the problem they're solving might not be the problem that's worthy of resources in terms of, delivering better outcomes, lowering costs, getting.
Yeah, this is a great topic, and this is a tough one to synthesize in the last couple of minutes. So I'm happy to talk to you offline about it if you want as well. I'm going to say something really controversial just to be fun, which is that there's been no value derived from Michael Porter and Elizabeth Teesberg's work. Okay, so there you go. Because look at, that work was published, more than 12 years ago. And how has the field progressed towards something that is more cost effective, more equitable, more, a better quality? I think that they got a lot wrong there, because the assumption is that somehow the care that I delivered before had no value, which is a kind of a strange thing to say to traditional physicians who've been working hard. And the thing that has really been missing is price. Like when you go to buy something, you assign value to it by how much you're willing to pay for it. And so this notion of value-based care, we've never answered the question, value to who? And so it's typically been the value to the payer. Now, the payer has a completely different universe of assumptions than the patient, and we've conflated the two. And so I think that the final thing I'll say about this is that this has become jargon without meaning. Okay, so when people say value-based care, it's great. I could go talk to my board about it, right? Like, hey, we're pursuing value-based care, and everyone goes, yeah, you should be in value-based care. That's great. What do you mean? Like, what exactly are you talking about? And if you really, break it down, you'll find that people, like people don't know what they're talking about. So we've jargonized it. It's lost its meaning. It's time for a shift. And I think that it was a good try. I have a lot of respect for Michael Porter, but I also think that it's important for him to recognize that this experiment in driving things in a direction didn't work. And that's okay too. He'll tell you that every business should understand when you set up a framework and that framework is no longer relevant, maybe it's time to change it. So I'd be more than happy to talk to you offline about this. I have a lot of views on this, as you can probably tell, but it's a tough one to encapsulate in the last few minutes. But thanks for asking.
Perfect. Well, I think we're kind of coming to a close. I know Connor had one last question to end with and really kind of culminate, but Connor, if you want to finish with that, and I think that's where we
All right.
I'll try to keep it quick. Thank you, Dr. Froimson, for all your insight tonight. I'm just curious, you talked about in the beginning, like it's very difficult to innovate within organizations, and they can, large organizations, and they can be kind of stifling towards innovation. What do you think, what can somebody who's a young, probably going to be a resident in these large organizations, what can I do to try to stimulate innovation? Or if I have a good idea, do you think it's possible to innovate in those large companies, or is really the startup kind of the way to go these days?
Well, no, I don't think it matters if you're in a startup or in a large organization. I think it's a matter of focus. The thing that startups do better than bigger organizations is they focus on a specific problem. The biggest mistake that people make is that they fall in love with their idea rather than understanding what utility that idea is actually going to bring to fore. And so, like, I don't care what your solution is. I don't care what your idea is. I want to know what problem of mine are you solving, right? Put yourself in my shoes, put yourself in the end user's shoes. And so the more specific you can be of solving a very identifiable problem that is longstanding and meaningful, that's where you'll find success as an entrepreneur, whether you're in a large organization or in a smaller startup. But it's often people fail for lack of specificity, lack of perspective. They have a driving passion and they get hung up in their passion for their solution, and they're often not willing to adapt their solution to the problem that the customer, that the target is having. So that's kind of how I would see it. And that's the work I do, is helping people see through the eyes of the person with the problem rather through the eyes of the person with the solution. And I needed to do that, by the way, as a surgeon. Like I can offer you a knee replacement, but if I don't understand why you're having it, what your goals are, that you want to dance at your daughter's wedding, right? Like, then it's not like I'm not really helping you until I can understand how that problem is impacting you. And then I can offer you the solution if it's the most appropriate one for your problem.
All right. Thank you. That was a great response. I really appreciate that.
Yeah, you bet. Happy to talk offline as well.
Yeah. Thank you.
Trey, is that it?
That's it. So first of all, I want to thank you for kind of taking the time today to talk to us, and everyone else who joined and had great questions. I think this was a great opportunity to learn and really kind of just change, open up a platform that was a great opportunity to communicate. So thank you all. And hopefully we can close it out,
Trey, thank you. You did a great job.
Thank you. Thank you very much.